Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarnet serves as a director partner for this event, and the focus of today's session is oxygen therapy. Now, I would like to invite Dr. A.L.Meeakshi Sundaram, sir. A distinguished anesthesiologist and academic leader, Sir has served as Dean and DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is a former National Vice President of the Indian Society of Anesthesiologists and has held key positions including Governing Council Member President and State Secretary of ISA Tamil Nadu State Branch. So without further any delay, over to you, sir. Thank you.
Thank you, as Rimpa and Clarinet, for the service they are rendering to the medical people. For this webinar, sometimes it coincides that it looks like a pan-Indian webinar. So I think 6 or 7 times it has come like that pan-Indian webinar. And today also it is going to be a pan-Indian webinar because the youngest speaker, the postgraduate Srinath, is from Puducherry, and Mohammed Riyaz Mohammed is from Karnataka, and Mohammed Riyaz is working in Karnataka, but he is basically from Andhra Pradesh. And the moderator is going to be a person from Tamil Nadu, Dr.Rajkumar. So 4 states are involved, and today I am happy to introduce Dr. Srinath, the youngest person. That is, he is a postgraduate in Puducherry. He is a Mahatma Gandhi Medical College and Research Institute, Puducherry postgraduate, and he is very much interested in managing all anesthesia and also assisted in ICU management, airway care, and post-operative pain relief. But more than that, as a youngster, what he has done is the extracurricular activities are huge. So he is an active participant in college, cultural, and sports events. He is interested in chess actually. So I am very happy that he is interested in chess because I happen to be a university chess player and I am captain of the Bharatidasan Chess University team. And I was participating in 2 All India inter-university chess tournaments in Nagpur and Hyderabad. In Nagpur, we finished third. So he is interested in chess, football, and cricket. So he is interested in curricular as well as extracurricular activities. He has organized so many department academic meets, and he is interested in football and cricket also. And the best part is everyone will be interested in reading a novel as a hobby, but this man is interested in reading anesthesia journals as hobby. So we welcome him to talk on oxygen cascade, and it will be followed by Aejaz Ahamed. So he is a associate professor and he is interested in simulation training. He is in Ennopaya Medical College. So he is interested in simulation training, resuscitation, intensive care, and regional anesthesia. And he is a training center coordinator, Advanced Comprehensive Clinical Training and Simulation Center, Ennopaya University. And his hobbies are badminton and cricket. So for PG is also interested in cricket. Once a time PG, Dr. Aejaz Ahamed is also interested in cricket. He is an enthusiastic person and he has even asked me, sir, shall I send my PowerPoint slides to you? That sort of a simplicity he has. And I said, Aejaz, I am not as intelligent as you. So you please uh, project your slides on your own and talk. So we welcome him to deliver a lecture on therapy and devices. So it will be followed by Dr. Mohammed Riyaz. He is from Narayana Hridalaya, Bangalore, but basically he is from Andhra Pradesh. I have seen him talking in Visakhapatnam, one of the conferences, wonderful conference they have organized, Dr. Praveen Kumar. So I'm happy to fix him as a speaker for this webinar. He has done MD anesthesia from Andhra Pradesh. but he is working in Narayana Gridhalaya in the cardiac anesthesia department, and he is a vice president and treasurer of AP Junior Doctors Association. So he is the active participant of association. And another point is he is also interested in cricket. So today it is a cricketing team participating in the webinar. So to manage this cricket team, we want a tennis player, that is Dr. Rajkumar. See, Dr. Rajkumar is going to moderate the symposium. I want to proudly introduce him that he has taken over as the state president of Tamil Nadu ISA a week back. So he is such an enthusiastic person from Tirunelveli. I have seen him in Tirunelveli when I was working as a professor there. So I'm very happy to have him here. And he is interested in intensive care and regional anesthesia. I have seen his expertise in managing critically ill cases. And he was the Tirunelveli City Branch Secretary for 6 years. And he is a Tirunelveli City Branch President for 3 years. Now he has become a president-elect last year, and he has taken over as president 2 weeks back. And he has presented many papers, mainly on IV fluid administration and in trauma patients, and in submental intubation, percutaneous tracheostomy, fat embolism, ABG interpretation. So everything is in critical care only. And his hobby is playing tennis. So by his appearance, usually Tirunelveli people will have a peculiar color for them, skin tinge. But this man is having a different tinge and a smiling face. It is an exceptional human being in Tirunelveli. He is doing a lot of charity work. He is running a school and he is helping the needy and poor. So I wish him all success in his endeavor as a Tamil Nadu state president. So Dr. Rajkumar, please take it over. Now the stage is yours.
Thank you very much, sir. So today is the oxygen therapy. This is the important topic because without oxygen, there is no surgery, there is no anesthesia, and in fact, there is no medical management also. So oxygen is like a medicine because as we know that without oxygen, we cannot survive. At the same time, too much oxygen also will harm our tissues. So all about this we are going to discuss today. So first of all, I want to call upon Dr.Srinath, postgraduate from Mahatma Gandhi Medical College and Research Institute, Puducherry, to give a talk on oxygen cascade. So I welcome Dr. Srinath to give his topic.
Yes, sir. Good evening, everyone. I am Dr. Srinath, second year postgraduate from Mahatma Gandhi Medical College and Research Institute, Pondicherry. I sincerely thank the dignitaries and Dr. Parthasarathi sir and Dr. Meenakshi Sundaram sir for giving me the opportunity to present in this webinar. Today, I am going to discuss about the oxygen cascade. Now we'll see. What is oxygen cascade? It is nothing but the sequential decrease in the partial pressure of oxygen from the atmosphere to the mitochondrial level. Why we need to know about this? Because to maintain the adequate oxygen delivery and its utilization. Now we'll see the steps involved in the oxygen cascades. Here I refer to waterfalls because like a waterfalls, the partial pressure of oxygen flows down from the atmosphere and it reaches the airway, alveolar, capillaries, arteries, and tissues, and finally reaches the mitochondria in the stepwise manner. This is called as the oxygen cascade. Now we will see the partial pressure of oxygen in the atmosphere. So the total barometric pressure in the atmosphere is 760 millimeters of mercury. In that 21% of the volume belongs to the oxygen. So that the 21% of the 760 is 159 millimeters of mercury, which is the partial pressure of oxygen in the atmosphere. Now we will see the journey of oxygen from the atmosphere to the alveoli. When we inhale into the airway, further reduction in the partial pressure of oxygen is there. So this is due to the process called humidification. The humidification is nothing but the adding of water vapor pressure to the air. So the partial pressure of oxygen in the airway is 149 millimeters of mercury. Then it further reduces into the alveolar. It's become 99 millimeters of mercury due to the dilution of the carbon dioxide. This value is derived from the alveolar gas equation. This equation consists of an FiO2, barometric pressure, and water vapor pressure, partial pressure of carbon dioxide in the alveoli, and respiratory coefficient. Now we'll see how it reaches into the artery. From the alveoli, it enters into the capillaries first. As the capillaries are devoid of oxygen, it will take the maximum amount of the oxygen from the alveoli to the capillaries. Now how it reaches the artery. We will see the A gradient. The A gradient is nothing but the alveolar arterial gradient. This is different from the patient to patient at the range of 5 to 10 millimeters of mercury in the young adult. So this difference depends on the two things. This is due to small venous admixtures of bronchial and sebaceous veins and ventilation coefficient mismatches. So if the patient has an A gradient of 7, then the partial pressure of oxygen in the artery is 92 millimeters of mercury. From the arteries, it will diffuses to the various organs such as brain, lung, kidney, every organs. So it will be differ from the partial pressure of oxygen in the tissue level is 30 to 50 millimeters of mercury. This is depends upon the coefficient, hemoglobin concentration, and oxygen extraction ratios. And the final marathon of the oxygen is end up in the mitochondrial level, where the oxidative phosphorylation occur. In the mitochondrial level of the partial pressure of oxygen is 2 to 5 millimeters of mercury. Now we'll see what happened when it reaches below the 2 mmHg of oxygen in the mitochondria. There the point anaerobic cycle starts. This point is called the Pasteur's point. Now we'll see the factors affecting oxygen cascades. The factors affecting oxygen cascades are altitudes, FiO2, ventilation coefficient mismatches, and cardiac output, anemia, which means hemoglobin levels, and anesthetic agents and diffusion barriers. Now let us summarize the oxygen cascade. In the atmosphere, the partial pressure of oxygen is 159 millimeters of mercury. When it reaches down the airway, it will further reduces to 149 millimeters of mercury by humidification. And again, when it reaches the alveoli, it further reduces to 99 millimeters of mercury. This is due to the carbon dioxide dilution. From the alveoli, it reaches to the atrial bloods through the by reducing the 92 millimeters of mercury due to A gradient difference. And when it further reduces by in the tissue level due to diffusion, depends upon the perfusion, hemoglobin, and oxygen extraction ratio. It will ranges from 30 to 50 millimeters of mercury. From there, it finally reaches the powerhouse of the cell, and it has the range of 2 to 5 millimeters of mercury. Now we'll see the one clinical example where the oxygen cascade can be applied. In ARDS patient, there is the widening of A gradient will be there, and ventilation coefficient mismatches also will be there. This can be overcome by improving the FiO2 level, which means the concentration in the atmosphere, to improve the partial pressure of oxygen in the arterial level in ARDS patients. I trust you all enjoyed the journey of oxygen from the atmosphere to the mitochondria. Thank you all.
Thank you very much. Thank you, Srinath.
Thank you, sir.
So about the oxygen cascade is given in a nutshell. How the oxygen from atmosphere to the tissue, how the cascade runs. And now next we are going to move on to the next topic, that is oxygen toxicity. Sorry, this is the oxygen therapy and devices. So I call upon Dr. Aejaz Ahamed, Associate Professor of NFI Medical College, Mangalore, Karnataka, to talk about the oxygen therapy and devices.
A very good evening to everybody present here. So at the outset, I like to thank Dr. Parthasarathi sir and Dr. Meenakshi Sundaram sir for having given me this opportunity and giving me an introduction as well. I bring greetings from my institute, Yanapoya Medical College, which comes under Yanapoya deemed to be university, situated in Mangalore, Karnataka. So a few things for the postgraduates. By the end of this presentation, expectation is going to be that you understand what sources of medical oxygen are available for patient use, what are the indications, what are your aims of providing oxygen to a patient, and what are the different methods and modes in which you can deliver oxygen to your patient. So a little bit about history. So we have heard this a lot. Joseph Priestley isolated oxygen in 1744, and Lavoisier deemed it as something necessary for life in the year 1777. And his first clinical use was by Haldane in 1919, where he saved a life of of First World War wounded soldiers who developed pulmonary edema and pneumonia due to war gases. And the first person to give oxygen to hospitalized civilians via a tent was by Dr. Alvin Barash in 1922. And the use of a hyperbaric chamber was introduced by Dr. Cunningham in the year 1928. So, what is oxygen essentially? So, we know it is a major gas in ambient air. It is a colorless, odorless, and a tasteless gas, which is essential for the body to function properly and for tissues to survive. When we say oxygen therapy, it generally means that you are administering oxygen at a concentration greater than what is seen in ambient air, which is 21%. And never forget that oxygen is a drug, should be treated as a drug, and it should be written in its required dosage, the rate, and what method of administration you want to give. So we know it is a key treatment in respiratory care, and the main purpose of providing oxygen, giving oxygen therapy, is to increase the oxygen saturation in the tissues where saturation levels are too low. Could be due to an illness, could be due to an injury. Now, what is our primary indication? Our primary indication is always if you have documented hypoxemia. So when we say documented hypoxemia, it generally means that your PaO2 is less than 60 millimeters of mercury, or you have an oxygen saturation level of less than 90% in patients breathing room air. And any in other circumstances, we also take into account that if your PaO2 is less than acceptable for your specific patient, for your specific clinical scenario, you also consider administering oxygen. So why do we have this value of 60 millimeters of mercury? Do not forget the P50 in your ODC curve. So we know that we have a sigmoid shaped curve where oxygen is half saturated at about 26 millimeters. And as we keep going up, it plateaus. And we know that when it drops below the P50, your PO2 starts dropping below 60 rapidly. So that is why we need to keep in mind of this number. So other cases, patients with severe respiratory distress, any acute conditions like exacerbations of asthma, patients with severe trauma where they could have had blood loss, oxygen carrying capacity is reduced, so you need to provide oxygen, etc. And chronic obstructive pulmonary disease like COPD, etc., where they require long-term oxygen therapy. Other conditions include pulmonary hypertension, acute myocardial infarction, where the load on the myocardium is high, you need to provide supplemental oxygen. And short-term therapy, primarily for anesthesiologists and our postgraduates, we generally have to routinely administer oxygen at least for a short period for every patient who has undergone general anesthesia. And we also know that oxygen can be used to treat chronic lung disease patients, patients with interstitial lung disease, etc. Other patient-related factors could include obese patients, patients who are shivering, where oxygen requirement is high, patients who have undergone thoracic and upper abdominal surgeries, where due to pain and poor movement of the diaphragm, they could have problems in breathing and require supplemental oxygen. Also, patients with hypovolemia, anemia, where there is a problem with oxygen delivery and utilization. And in patients, in certain cases where you have patients with patient-controlled anesthesia, including opioids, you might have to provide supplemental oxygen. What are our clinical cues to tell us that, okay, my patient is probably going to require oxygen? So your patient could be dyspneic, could be having a high respiratory rate, could be having signs of tachycardia, could be presenting any arrhythmias. Patient could be anemic. They could show other CNS signs like restlessness and nausea. And you could also notice cyanosis. So what is our goal? What is our aim in providing a patient with oxygen? So the most important aim is nothing but to relieve or to prevent hypoxemia, reduce the work of breathing of your patient, decrease the work or load on the myocardium, and improve exercise tolerance. So, what are the sources of oxygen available to us? So, we know that oxygen is available from your anesthesia machine point of view. It is available from the cylinder, from your high pressure system, and you have other wall outlets as well. So, one thing to keep in mind is oxygen is moistened by passing it through a humidification system to prevent the mucous membranes from drying up. That is the most important point. So, you need to make sure oxygen is humidified, although some people do disagree with this nowadays. Now, if you take our cylinder into account, we know it, cylinders have a particular safety feature. They have certain mechanisms. You need a flow meter and a reduction gauge to help us in delivering oxygen at the amount which is required. So this is just a picture of how we have the flow meters and our pressure gauge attached to our oxygen cylinders. So we know in the hospital, when you have a central pipeline system, where is our oxygen going to come? It is going to come from the manifold. And most of the large hospitals make sure they store oxygen as liquids so that it is utilized in a more efficient way. Because we know liquid oxygen gives rise to multi-fold, or let's say about 1 liter of liquid oxygen gives you about 800 ml or 800 liters of gaseous oxygen. So making it easier to store. So from our manifold, we have our wall outlets. So through which we just connect a flow meter and a humidifier, and through which we utilize and provide oxygen. Now, how do you prepare by to administer oxygen to your patient? So a clinician's order is always required for oxygen therapy, except in emergency situations. You also need to rely upon your clinical observations, as I mentioned earlier. And oxygen supplementation is primarily determined by inadequate oxygen saturation, like we first mentioned. So how are you going to get your oxygen saturation? Could be through a simple pulse oximeter, also could be due to your arterial blood gas measurements. Coming to delivery systems, we broadly have two categories where we have low flow systems, which are basically variable performance devices, and high flow systems, which have a fixed performance. So in low flow systems, we need to remember that they basically contribute partially to the inspired gas that the patient breathes, and they do not usually provide a constant inspired oxygen concentration. So examples of which are nasal cannulae, simple mask, a non-rebreather mask, or a partial rebreather mask. And we have other high flow systems, specifically something like a Venturi mask, which we use routinely. So these deliver specific and constant percentage of oxygen, which is usually independent of your patient's breathing. Whereas in a low flow system, they are variable performance. Why? Because as per your patient's inspired gas, your concentration of oxygen which the patient is inspiring can vary. So both systems can deliver a wide range of FiO2, and it is a common misconception that low flow systems deliver low FiO2 and high flow systems deliver high FiO2, which is not the case. And we should also make sure as postgraduates, please do not confuse low flow and high flow with a low inspired oxygen concentration or a high inspired oxygen concentration. So coming to nasal prongs, it is a plastic device with two protruding prongs for insertion to the nostrils, which is connected to an oxygen source. It is the most simplest oxygen delivery device which we use, and it is primarily used for low to medium concentrations of oxygen. So your FiO2 can basically vary to somewhere between 24-25% to about 40%, depending on the flow rate which we set as. Now, few things you need to remember with nasal prongs are you have to make sure your prongs are in both your patient's nostrils. And it is always ideal that you do not deliver more than 2 to 3 liters per minute of oxygen to a patient with chronic lung disease, especially due to the fact that it can cause more drying and also that it could decrease their hypoxic respiratory drive, ventilatory drive. Advantages are that your client is able to talk, eat with oxygen in place. There is no hindrance, there is no claustrophobia, etc., and can be easily used in a home setting as well. The only problem is that it can cause irritation to the nasal and pharyngeal mucosa. And with oxygen flow rates more than 6 liters per minute, you end up getting very varied FiO2. So the other most common oxygen delivery device we use are nothing but your face masks, which could be a simple oxygen face mask, a partial rebreather mask, or an NRBM, the non-rebreather mask, and the other high flow system, which is your Venturi mask. So going into a simple face mask, we know it is made of a clear flexible plastic or rubber that is in a molded shape that can fit the face, and it is held to the head with elastic bands, or you could have metal clips. So the FiO2 generally achieved is about 35 to 60% or about 50%. And we need to remember that a flow rate of 5 to 10 liters per minute is always required. So a higher flow rate is required here. And any flow rate less than 5 liters would generally lead to rebreathing. So a point to remember for our postgraduates is that please make sure when you advise oxygen therapy with face mask, you start at a minimum of 5 liters. So these face masks have vents on the side which allow room air to leak in at many places, thereby diluting the source of oxygen. So we need to keep in mind that although we are administering oxygen, pure oxygen, you are not going to get or be able to deliver 100% of oxygen. Why? Because your ambient air and whatever the patient breathes in, it dilutes the oxygen from the source. So we often use it when an increased delivery of oxygen is needed for short periods, in general, less than about 12 hours. So few things to keep in mind. Monitor your patient frequently to check the placement of the mask. Patients who have claustrophobia can end up pulling the mask. You might not be giving oxygen at all times. So you have to make sure your nurses monitor your patients and make sure you always secure a physician's order to replace a mask with nasal cannula when your patient is ready to have a meal. This mostly happens for patients on slightly longer term therapy. So the major advantage here is that it can provide increased delivery of oxygen for shorter periods. And the bigger problem is that you require to have a tight seal to make sure you deliver your concentration which you intend to give the patient. And it's difficult to keep the mask in position over the nose and the mouth. And there is a potential for skin breakdown as well if you use it for longer periods or if the straps are too tight. So coming to a partial rebreather mask, it is a mask which has a reservoir bag and which must remain inflated during both inspiration and expiration. So it collects the first part of the patient's exhaled air and can provide up to 70 to 80% of inspired oxygen concentrations. So here we have to keep in mind that again, you need a minimal flow of 6 liters per minute to ensure that your patient does not rebreathe large amounts of exhaled air into your reservoir bag. And the remaining exhaled air usually exits through the side vents. So like I said, we can go up to 70 to 80% of oxygen. We have to make sure your mask is covering the face properly and your reservoir bag is free of twists or any kinks. Patient can inhale room air through the openings in the mask if oxygen supply is briefly interrupted because there is oxygen remaining in the reservoir bag. And let's say there is a tube disconnection, etc. Patient can still inspire room air and ambient air. The similar issue which we have with your face mask is the same. Like you require a tight seal. Eating and talking could become difficult. It could be uncomfortable to the patient, but is again not as drying to the mucous membranes. So what is a non-rebreather mask? So as the name suggests, it is a device which has two one-way valves which prevents any expired air from entering into the reservoir bag, because of which you can deliver up to 100% of oxygen if you have a flow rate of 6 to 15 liters a minute. So when your patient exhales air, the one-way valve closes. So we can notice these one-way valves on the side. So there could be one or two one-way valves on the same place where you have the side vents in a partial rebreather mask. So through the one-way valve, the expired air is pushed out and fresh oxygen is inspired in through the reservoir bag. So, like I said, it delivers the highest possible oxygen concentration. It is suitable for patients breathing who are spontaneously breathing, but with severe hypoxemia. And more importantly, it is a device now. Let's say we don't have your patient is breathing spontaneously, could be having increased work of breathing. We do not have a transport ventilator. So, to make sure we deliver the highest amount of oxygen or highest concentration of oxygen, usually we end up using the non-rebreather mask. So one issue is that it is not very practical for long-term therapy. There could be malfunctions which cause a CO2 buildup, could cause suffocation. It is slightly more expensive and it is definitely uncomfortable. So coming to your high flow system, which is a Venturi mask, we very commonly hear of this mask which we use in a varied group of patients. It has a constant flow of room air blended with a fixed concentration of oxygen, which is basically provided by through various color-coded different sized jet orifices. So we know the Venturi effect here. Pressure drop occurs across the orifice as air entrainment occurs through the side ports, leading to a fixed amount of inspired oxygen concentration. So the Venturi mask has a whiteboard tubing and various color-coded jet adapters, which correspond to the approximate FiO2 which they deliver. And the room air dilutes the oxygen entering the tubing to a certain concentration, and the amount of air is which is drawn in is determined by the size of the jet adapter or the orifice in the jet adapter. So these are the common colors which we see. So from about 24% to about 60%, we can deliver inspired oxygen concentrations. And we also need to make sure we follow the amount of flow rate which we have to keep, which is mentioned on each adapter. So we can, the biggest difference is that we can deliver fixed oxygen concentrations, more precise. It doesn't drive mucous membranes, and but it does have a risk for skin irritation and can provide respiratory depressions in patients with COPD. So patients with COPD, we are not going to target very high oxygen saturation. We usually try to keep a limit of 88 or so. And we also have to keep in mind higher concentrations of oxygen, say more than 40 or 50% in such patients, can decrease their ventilatory drive and can further cause deterioration rather than actually helping us in such a case. So other devices are tracheostomy collars or masks, which are inserted directly into the trachea. It's mostly indicated for long-term oxygen therapy. And O2 flow rates are generally in the range of 8 to 10 liters. They provide accurate FiO2, provides good humidity, comfortable, more efficient, and less expensive for long-term therapy. So something which is more specific to children or neonates, oxygen hoods. So these are transparent enclosures designed to surround the head of an infant, something which we very commonly see when we enter the NICU. So it provides continuous humidified oxygen which is supplied to a hood, and it is usually only for short-term use, and a minimum flow rate of 7 liters is necessary. We also have to keep in mind that you have to keep monitoring the child. You have to make sure alarm systems are in place. You have to make sure if the child moves, the hood has to be positioned accordingly, etc. So other methods in which we usually end up delivering oxygen. So patients which require non-invasive ventilation, NIV, could be patients with obstructive sleep apnea who require a BiPAP mask through the night. So we know we deliver ventilatory support through a specialized face mask. Could be a small device, like I said, a BiPAP machine, or you could be delivering, or you could be administering NIV, non-invasive ventilation, through a ventilator itself. Mostly of use in ARDS, acute respiratory failure, and pulmonary edema. So the biggest problem, it usually comes with a standard size mask, which has to be tight fitting, and it can, over long term, this is something which we very commonly saw during COVID. It ends up causing pressure sores over the bridge of the nose. So mask has to be tight fitting, or ventilation could be poor, and your patient is not really going to get the amount of oxygen which is really required. And mouth breathing will again cause insufflation of the stomach rather than actually helping in ventilating the lungs. So this is something which we use very commonly, which we use in our ORs, which we use in our ICUs. So the mechanical ventilator is something which we need to know has been a great invention, which helps us give positive pressure ventilation to our patients. So just as a throwback, we have to remember that we used to have negative pressure ventilators, which were iron lungs, which are still in use by 1 or 2 patients throughout the world. Basically, it was used in patients who were polio survivors. So a small word on hyperbaric oxygen therapy. So when we say hyperbaric, it means that you are delivering oxygen or you're providing oxygen at a pressure which is about 3 times higher than normal atmospheric pressure. So it involves breathing pure oxygen in a pressurized room. So it could be a pressurized room, it could be a pressurized tube. So it's a well-established treatment for decompression sickness, and other indications include an air embolism, long-standing non-healing diabetic wounds, or any history of radiation exposure, injury, or carbon monoxide poisoning. It could cause a temporary feeling of fullness in the ears due to increased pressure, because we have to remember it's providing oxygen at a pressure about 3 times more than atmospheric pressure. So there is a single person chamber and a multi-person chamber or a room to provide hyperbaric oxygen therapy. So to conclude, for postgraduates, please keep this in mind. You have to make sure you choose the right system for the right patient for the right amount of time. Make sure you select your FiO2 appropriately for your patient, adjust as per your patient's requirement. Patients could require addition of intravenous fluids. Patients with hypovolemia, you could require blood where, say, your patient has had a lot of hemorrhage. You need to make sure you increase the hemoglobin level so that it increases the oxygen carrying capacity. And please don't forget, oxygen is a drug. Make sure you give specific orders. we usually end up hearing our postgraduates most of the time as they walk through the POR, yes, sister, please give oxygen for a while. Please remember that is not the way to be done. Let us not forget that we have just come out through a major pandemic where there was acute shortage of oxygen, and we in fact lost a lot of lives just because people could not be given oxygen at the right time. So please give specific orders. For example, please deliver humidified oxygen through a face mask at about 5 liters per minute for 4 hours. So please make sure you give specific orders. Thank you everybody for listening.
Thank you, Ajis. Thank you for your excellent presentation. And not to mention that oxygen is a drug that is very important to we have to remember. And oxygen is not an ever available element as such. And few points he reiterated. That is, don't confuse with the high flow mask with the high flow rate and low flow mask with the low FiO2 like that. And also another important thing is oxygen mask means you have to give minimum 5 liters. The less than that is not efficient. That will produce rebreathing. That point should be kept in mind for all the oxygen providers. And another thing I want to mention is non-invasive ventilation is also an oxygen therapy machine, but it can be used as a non-oxygen therapy machine also, just to deliver pressure where it is required. And also he mentioned about the orthobaric oxygen therapy and hyperbaric oxygen therapy. So the excellent presentation. Thank you very much.
Thank you.
Now, since oxygen is a drug, all drugs will have their own side effects. So you have to care about the oxygen toxicity. Now I call upon Dr. Mohammed Riyaz from Narayana Hridayalaya, senior resident. Please welcome Mohammed Riyaz to
Yes,
talk
thank
on
you.
the oxygen toxicity.
Yes. Mhm. So good evening, everyone. I thank Dr. Praveen Kumar Moturi, sir, and Dr. Meenakshi Sundaram, sir, and Dr. Rajkumar, sir, for the introduction and giving me this opportunity to speak on this wonderful platform. So, greetings from my institute, Narayana. So, let's continue the momentum that has set by Dr. Srinath and Dr. Aejaz, sir. So, first of all, before going into the topic, I want everyone to imagine this situation where one of your patients has appeared like this, like they are gasping for the air. So what is the first thing that gets into your mind, and what you are going to do? What is the reflexive action that you are going to do? So obviously you will uh, uh, doubt that the patient is craving for oxygen and air, and will literally reach out for the oxygen mask and whatever the oxygen source that is available for us, and connect it to the patient. And without any intention or deliberation, we start giving high flows of oxygen to this patient. So there is nothing wrong in giving high flows of oxygen in this patient, as it is an acute requirement, otherwise acute hypoxemic condition. So, and what, because providing that high flow oxygen, or maybe it is an invasive or non-invasive method, it is going to save this patient's life. So providing oxygen in this kind of situations, acute situations, is going to definitely saving this patient's life. Then here comes the paradox. So this very gas that keeps us alive can also quietly damages our lives. So as an anesthesiologist, we daily work with the oxygen. We work in ICUs, we work in operation theaters, we prescribe oxygen, uh, we provide the oxygen to the patient. We monitor its rate, we monitor its volume, we monitor its effects, and we are also aware of its toxic effects. I hope everyone is aware of toxic effects of the oxygen gas. So we prescribe means we should know the indications, as nicely dealt by Dr. Aejaz. We should know the indications of oxygen provision, and we should monitor whatever the oxygen rate and volume we are giving. by invasive, non-invasive techniques. We have like pulse oximetry and arterial blood gas analysis. And we should also be aware of its toxic side effects so that we can withdraw it in time. So already Aejaz sir has mentioned that it should be treated as a drug, because like any drug, it has its dose, route, indications, and we should monitor its rate and volume, and we should be aware of its toxicity. As already said, Joseph Priestley is the first to isolate the oxygen by heating the mercury dioxide. Yeah. So he only quoted that pure oxygen might not be so proper for us in the usual healthy state of body. What he meant to say is there is an indication to give the oxygen, to provide the oxygen, unless until a normal patient or healthy patient, and the patient who doesn't require oxygen should not be given oxygen deliberately if it is not required. He meant to say that. And Lorraine Smith is the one in 1899 described the pathological changes that has occurred in the mice when he exposed it to the hyperbaric oxygen. He stated that the effect was uniformly fatal and the immediate cause of death was inflammation of the lungs. And the lungs were found post-mortem to be extremely congested, that they are filled with that the alveoli are filled with the exudative neutrophilic material. He meant to quote the pulmonary toxicity that has caused by this hyperoxia, that is increased oxygen levels in the mice. So oxygen toxicity is not just in medical books. It has also been there in other science books, even in tales, stories in which Andy Weir, one of the science fiction author, has nicely mentioned in his storybook, in which one of his characters is an astronaut. In this situation, that astronaut's space suit has got damaged and it started leaking. So once it started leaking, the partial pressure of oxygen has fallen down, calmed down. And to compensate it, there is backup oxygen cylinders present for that suit. So as soon as there is a fall in the partial pressure of oxygen, the backup cylinders started pumping oxygen into that suit. So immediately there is a super high rise in the partial pressure of oxygen, leading that character to expose it the high amount of oxygen. That is where this para he stated that I now risk dying from oxygen toxicity, as the excessively high amount of oxygen threatened to burn up my nervous system, lungs, and eyes. And ironic that for someone with a leaky spacesuit, that is too much oxygen. So that is how it is mentioned in that tale. So let's go into the topic, oxygen toxicity. So I'll be dealing with these contents, definition, high-risk groups and factors that high-risk factors, mechanism of oxygen toxicity, protective mechanisms, systemic manifestations, and the management part. So to define, hyperoxia is something which there is excess of oxygen in the body tissues or blood beyond the normal physiological range. To put it in measurements, it is the partial pressure of oxygen more than 120 mmHg. Some literature has quoted it as 100 mmHg, some as 150 mmHg. It is from standard source that it is more than 120 mmHg, and fraction concentration of oxygen of more than 0.21, but we should keep in mind the length of the time we're also providing. It is also should be taken into consideration. So high risk groups, the patients who are provided with a high concentration of supplemental oxygen for longer duration, that is 100% oxygen for 8 to 12 hours. And the patients who are on mechanical ventilation, either it is endotracheal tube intubated patients or tracheostomized patients, if we are providing oxygen to them with high FiO2, it will also exposes them to the risk of hyperoxia. And the premature babies, infants and neonates getting 100% oxygen for more than 2 to 3 hours. It is very less in case of infants and neonates compared to the adults where it is 8 to 12 hours. In infants and neonates, it is just 2 hours. If you are giving 100% oxygen for a infant or a newborn for 2 hours, it will definitely land them into a hyperoxic condition and definitely will be going to see that oxygen toxic effects. And another thing is the hyperbaric oxygen therapy and last chemicals like bleomycin. Patients who are taking this chemotherapy drug bleomycin are also at a risk of oxygen toxicity. So let's see what is the pathophysiological basis or biochemical basis of this oxygen toxicity. I want everyone to recollect and remember this electron transport chain, which we have read in our +1, +2 classes. If you remember, after glycolysis and NADPH reduction, the third step is the electron transport chain. The NADPH or FADH2, which gives the electrons to this electron transport chain, that will be transferred from complex 1 to complex 4, then it will be collected by oxygen at the end. So while transferring these electrons, protons will be moving from mitochondrial matrix to the intermembranous space. And these protons will be used for the generation of ATP. So what happens to that electrons that has been transferred from complex 1 to complex 4? The electron that is transferred from 1 to 4 will be received by oxygen at the end, and the oxygen will be reduced to water. This is what happens in a normal individual with normal oxygen levels in the mitochondria. So what happens if there is a condition of hyperoxia? So this hyperoxic condition leads to excessive accumulation of electrons, and there is a instability in the mitochondrial matrix, because this hyperoxic condition creates an oxidative environment in the mitochondrial matrix that causes instability of these complexes, that is complex 1 to 4. And these electrons started piling up, like it started piling up, backing up, like they won't move forward, the backup at complex 1, complex 2, and complex 3, and started leaking into the matrix. Some of the electrons will be reducing this oxygen, but incompletely or partially reducing this oxygen, leading to the formation of the culprits of this whole toxicity that's known as reactive oxygen species, in which superoxide anion is the main culprit. So these are the culprits of our tail: superoxide anion, pronated superoxide, hydrogen peroxide, hydroxyl radical, and peroxynitrate. So these are called as the reactive oxygen species. Protective mechanism, even though there are some reactive oxygen species getting produced in our body every single minute, every single second, but these are handled by these enzymes like superoxide dismutase, catalase, and glutathione peroxidase. These three enzymes are the main enzymes that are present in every bodily tissue that will be neutralizing the superoxide and hydrogen peroxide ions and reducing them to water and oxygen. Also, we have extracellular antioxidants like vitamin C, vitamin E, ceruloplasmin, and cysteine taking care of this reactive oxygen species. So once these reactive oxygen species are produced in excessive amounts, this will overcome the cellular defenses, causing death or mutagenesis of the cell. So let's see what these reactive oxygen species are doing. This reactive oxygen species will damage different tissues wherever they are getting produced. In lung, what they causes is they depletes the pulmonary vasoconstriction reflex, whichever hypoxic pulmonary vasoconstriction reflex that is present, and that will lead the patient to land up in a condition of hypoxia and will lead to the acute respiratory distress syndrome. In vasculature, it will suppresses the production of nitric oxide, which will lead to severe vasoconstriction, and that will land the patient into decrease in microvascular perfusion. So in mitochondria, as we discussed, it creates an oxidizing environment, and there is a excessive pooling up of the electrons in the complex 1 and 2 itself. It is not getting advanced to the complex 4 and not received by the oxygen. What happens is ATP generation generally gets stopped. So to compensate that ATP depletion, the glycolysis becomes the main source of ATP production. So it chooses the anaerobic pathway to produce ATP, and which finally leads to formation of excessive amounts of pyruvic acid, and patient will land into acidosis. And it will also causes the DNA damage and uncoupling of mitochondrial respiration, leads to the initiation and triggering of inflammatory cascade. So we'll see system-wise how this pathophysiology is going to affect every single system. In lungs, actually the human lung tissue contains a high concentration of this extracellular oxidants, whatever we discussed, like vitamin C, E, and ceruloplasmin. And there are also high amounts of superoxide dismutase isoforms that allows the lungs to get exposed to higher concentration of oxygen without developing any toxicity. So until unless there is FiO2 of more than getting less than 0.5, there won't be any pulmonary clinical toxicity. So once this FiO2 is crossed that 0.5 number, then for a prolonged period of time, then comes this pulmonary toxic effects. It occurs in two phases: exudative phase and proliferative phase. In exudative phase, there is alveolar type 1 endothelial cells getting damaged and landed up in death, which will leads into interstitial edema and exudative neutrophilic alveolar filling. In proliferative phase, which is followed by exudative phase, leads to the proliferation of endothelial cells and type 2 pneumocytes. Finally, this pathology lands up by fibroblast proliferation, interstitial scarring. But here the capillary endothelium and alveolar epithelium are preserved. That is, the oxygen exchange will be preserved. So let's see the agents which are causing this pulmonary oxygen toxicity, like clinical manifestations in pulmonary oxygen toxicity. Exposure to nearly 100% oxygen results in paresthesias, nausea, tracheobronchitis, and decrease in vital capacity, diffusing capacity, lung compliance, and pH. So other relevant concerns over oxygen toxicity with respect to pulmonary system includes absorption atelectasis. So let's see whatever the 21% oxygen we are taking daily. It will be like mixture of gas we are inhaling. It consists of 21% oxygen and remaining is the nitrogen. So this nitrogen has less diffusing capacity of all gases that is going into our lungs, and that it will maintains the patency of alveoli and prevents it from collapsing. So what happens when you give 100% oxygen without giving any other carrier gas? So if you are giving 100% oxygen, so that oxygen will go to the alveoli and it diffuses immediately into the blood. So whenever there is a area in the lung with low V by Q ratio, so in those areas, this 100% oxygen will be immediately diffusing into the blood, and there is no carrier gas like nitrogen to maintain the patency of the alveoli. That will lead the patient to land in absorption atelectasis. And next one is the oxygen-induced hypercapnia. This is very important thing we should remember with respect to the oxygen delivering while they are delivering oxygen. Already Aejaz sir has mentioned about this thing, hypercapnia. So there are some patients like COPD patients who are known as the CO2 retainers. In normal healthy patients, hypercapnia is the trigger that will stimulates the central receptors that are present in the medulla, that is respiratory breathing center, and they initiates the breathing. But in case of these CO2 containers or COPD patients, it is not hypercapnia, it is hypoxia that is driving the patients to initiate this breathing. And if in these patients you are going to give 100% oxygen, high FiO2 or high flows of oxygen, this hypoxic drive will get depleted. This hypoxic drive will get depleted and the patient will eventually going to land in a severe respiratory acidosis due to increased CO2 levels in the body, and patient will land into respiratory arrest. So next condition is acute respiratory distress syndrome and bronchopulmonary dysplasia. These conditions are mainly caused due to the inflammatory cascade that has been set up by the reactive oxygen species in the lung. So we are bronchopulmonary epithelium gets degenerated, disturbed, and it will leads to the dysplasia. So potentiation of pulmonary oxygen toxicity, chemotherapeutic agents like bleomycin and in paraquat poisoning and some protein and nutritional deficiencies. If any of the patients are in these conditions, if you are giving 100% oxygen to these patients, obviously eventually the patient will be landing up into the potentiating. We are going to potentiate this hyperoxia toxic effects. So coming to the CVS, what happens in cardiovascular system is, yeah. So we have seen the slide that reactive oxygen species are going to act on vessels and suppressing the production of the nitric oxide, causing vasoconstriction. It is same in it is going to happen with coronary circulation also, coronary vessels also. The coronary vessels get constricted, and there will be a myocardial coronary vasoconstriction that leads to decreased supply to the myocardium. And to compensate compensate the demand, there will be a decreased heart rate and decreased cardiac output. So even in cardiac patients, in cardiac surgeries also, what we generally think is, to maintain the oxygen demand and balance, we start giving high FiO2s. Like in our center, cardiac patients, we give we won't give high FiO2 because it is a general misconception that as to maintain the myocardial oxygen demand and balance, we have to give good oxygen, high flow oxygen, high FiO2. But if we are going to do that, this what happens is this vasoconstriction, coronary vasoconstriction gets worsens, and even though there is a good oxygen, there is no supply. There is no coronary supply to the myocardium. That will land up the patient into more demand. That will worsen the cardiac condition, whatever the patient is having. So that is what has to be remembered in case of cardiovascular system with respect to oxygen toxicity. And in nervous system, there is a trigger. Again, it is also due to cerebral vasoconstriction due to the suppression of nitric oxide. There is activation of parasympathetic nervous system. There is this effect known as Paul Bert effect. It is discovered by Paul Bert, French physiologist in 19th century. The cause of this effect is due to breathing of high partial pressure of oxygen, that is more than 1.6 atmospheres, which is usually seen in diverse or hyperbaric oxygen therapy. Here, the high oxygen tension is going to produce excessive amounts of reactive oxygen species, which causes this neuronal excitability. This neuronal hyperexcitability will lands the patient into seizures and other clinical features like visual disturbances, tinnitus, nausea, dizziness, twitching, irritability, and anxiety. So coming to the renal system, same like coronary and cerebral, it is also the renal vasoconstriction that is going to deplete the kidney of its kidney from its blood circulation. It will lead into acute kidney injury, finally to chronic kidney disease. And as in vascular system, we have already dealt with it by like decrease in nitric oxide increases the systemic vascular resistance, causing vasoconstriction. So in eye, what happens in especially in newborn babies, what happens is there is retinal vessels are not like fully developed. That vascular endothelial growth factor is not yet developed in these babies. So what this hyperoxia does is these reactive oxygen species are going to suppress this production of vascular endothelial growth factor also. So once this vascular endothelial growth factor is not developed and not gets suppressed by this reactive oxygen species, the retinal vessels are not going to develop. The retinal vessels will be damaged, and this leads to a condition in the baby known as a retinopathy of prematurity, even in premature babies. So after seeing this biochemical basis of this toxicity and what are the effects, systemic manifestations, what is the best thing management we can do? Good is that if you treat the patient with oxygen toxicity is good. Better is to identify the patient that who is getting exposed to high oxygen. Best is to prevent the patient from getting exposed to the high oxygen. So how will we know that what is the safe oxygen administration? What is the safe oxygen that has to be given to a particular patient? So we generally depend upon these parameters to provide the oxygen, that is concentration of oxygen, that is FiO2, flow, volume, and percentage. As Aejaz sir has said, that shouldn't be get confused between FiO2 and the flow. Flow or volume or percentage of oxygen is something we are providing from our side, that is our end, that is source of oxygen. But 100%, 80%, or 70%, whatever, it depends upon we're giving complete oxygen or we're mixing it with any other carrier gas. FiO2 is something the concentration of oxygen at the level of alveolus. We shouldn't get confused it with what are the source that providing it. That is a volume that is we are providing, and what is reaching at the level of alveoli. So the third parameter is the target SpO2 and PO2. Concentration of FiO2, safe range is 0.3 to 0.4% in depending upon the type of the patient actually. If it is short term, and in case of acute conditions or emergencies like cardiac arrest and in acute hypoxic conditions, acute respiratory distress syndrome, in that we can give 100% oxygen or 1.1 FiO2 concentration for short time. As soon as the patient starts recovering and getting better, you can taper that FiO2 also. So prolonged FiO2 of more than 0.6 will definitely going to increasing the risk of this hyperoxia. And the second parameter, flow or volume, as discussed by previous speaker, there are different devices, oxygen delivery devices, which has the capacity of delivering different flow volumes and at a different FiO2. So we have to identify the patient, we have to identify the condition of the patient, and even accordingly, we have to connect or provide the oxygen with that particular device, and preventing him to land up by taking high FiO2s or high flows. So third parameter is the target SpO2 or a partial pressure of oxygen. Most patient can be managed with oxygen saturation of 92 to 96%. Except in the acute hypoxic condition, we can go to 100%, we can maintain 100%, but it is also okay to maintain between 94 to 98%. And as I said before, there are patients like CO2 retainers or COPD patients who are dependent on hypoxia to continue their breathing cycle. In these patients, you can maintain the oxygen saturation between 88 to 92%. You shouldn't need to have this patient of oxygen saturation of 96%, 100%. We don't need that. So critically ill patients, PaO2 of 60 to 80 mmHg, we have to maintain, especially in ICUs, where we have the access to measure the PaO2 by arterial blood gas analysis. So these are some conditions where we need a high oxygen flows for a short period of time. That includes the cardiac arrest, CO poisoning, severe trauma, acute respiratory distress syndrome, cluster headache, pneumothorax with persistent air leak. And as I said before, these are the patients who are known as CO2 retainers. In these patients, we should be careful while giving oxygen. We should not aim for high oxygen saturation, and we should not provide high FiO2. This includes the COPD patients, obesity, hypoventilation syndrome, severe long-lasting obstructive sleep, long-standing obstructive sleep apnea, neuromuscular or chest wall disorders, chronic respiratory failure, or patients with the cystic fibrosis. So after providing the oxygen, we're just not giving the oxygen to the patient, and once the surgery is done, when the patient is getting better, we have to disconnect. It's not like that. How we know that the patient is getting adequate amount of oxygen? We have both the invasive and non-invasive methods. Invasive methods includes arterial blood gas analysis. So non-invasive includes the regular pulse oximeter we use in our ICUs and OTs, and there is a co-oximetry present, which can monitor different types of hemoglobins in your blood. So finally, safe oxygen volume or concentration isn't a fixed number. There isn't a fixed number to say this is the FiO2 you have to give this patient, this is the volume you have to give. It depends upon the patient's condition, the device we are using, and the targeting, the SpO2 and PO2 we are targeting. So start higher if he is hypoxemic, then titrate down slowly and accordingly. Use the lowest FiO2 that maintains the safe oxygen. So in between the connecting and disconnecting, there are two important steps that has to be done without even the patient is a normal patient with hernia or any minor surgeries or whatever the patient situation condition is. You have to monitor and titrate the oxygen. If you are not going to do these things in between the connecting and disconnecting, definitely allowing the patient to land in this risk of hyperoxia, that is oxygen toxicity. So too much of good thing is bad. Oxygen is of no exception. Yeah. So these are my references. Thank you.
So thank you, Mohammed Riyaz,
Yes.
for your excellent presentation. See, oxygen is a drug, so you should be administered with caution, and with no exception, too much of anything is bad, even oxygen. And as we know, we have 1/5 of our atmosphere is filled with oxygen. That doesn't mean that for any patient we should pump the oxygen so that we can treat the patient like that. And always we should remember oxygen is given inadequately. So one point he reiterated is the target of oxygen should not be 100%. It should be less than 100. That is 98 is enough. So like that, these points are very important. And now at the end of the session, all these three speakers, they explained the topics very clearly. So one about the oxygen cascade, the next one about the oxygen therapy, and the final speaker about the oxygen toxicity. Now we have a very good idea about the oxygen therapy. So thank you very much for arranging this excellent and a very useful topic, Dr. Aejaz sir. Now I hand over the mic to Meenakshi sir for a vote of thanks. Thank you, sir.
Thank you, Dr. Rajkumar. I'm very, very happy that a basic teaching, which is not being taught in many of the medical colleges, has been discussed in this Pan-India webinar. Because people forget that oxygen is a drug. When I was administrator, I have insisted without doctor's prescription, oxygen should not be administered by the staff nurses. That should be a part of it, and anesthesiologist has to take a lead role in that. So I thank Dr. Srinath, the postgraduate from Puducherry. He has given a wonderful lecture about oxygen cascade, and I am very happy that Dr.Aejaz Ahamed, because after a PG, it was followed by a chief cadre officer about therapy and devices, because he has dealt in length about the amount of oxygen and the duration of oxygen, and even rebreathing and partial rebreathing mask he has discussed very well. And it was followed by Dr. Riyaz about oxygen toxicity, because I have heard him in Vizag. It was a wonderful lecture. And today I thank these faculty from Puducherry and Karnataka, and working in Karnataka from Andhra Pradesh. And it was fantastically moderated by Tamil Nadu State ISA President, Dr. Rajkumar. We have to give the whole credit to him for handling with much ease, because he is interested in critical care, and he is working in one of the finest nursing homes in the Tirunelveli district. So I congratulate the entire team, and tomorrow I'll get back to you personally regarding the feedbacks and the number of attendees. Now over to Clearnet, Ms. Rimpa, for concluding remarks.
Thank you so much, everyone, for joining this session. Clarnet is really glad to have all these brilliant people together. So, with all your permission, I'm closing the session for today and looking forward to hosting you again. Thank you so much, everyone.
Thank you. Thank
Thank
you.
you, sir. Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you, sir.